And on behalf of my committee and myself, I want to thank each of you for accepting our invitation to come here today. Our committee is charged with considering legislation to improve health care for all Montanans.
We find ourselves at a unique time in history where we have an incredible opportunity to have a national discussion which may result in a positive and healthier outcome for all of our citizens across Montana and in this nation. As this national dialogue occurs, it is imperative that the voices of Montanans be heard.
In study over study, particularly with Medicare costs, Montana ranks in the lowest quartile in terms of cost per beneficiary per year, i.e. 75% of states are spending more per Medicare beneficiary than we are here in the state of Montana. At the same time, we consistently rate in the top 25 percentile in quality measures. So we are seen by federal policymakers as a value state. How can we migrate that into the larger picture, which also includes the commercial insurers, and bring more of our uninsured patients into coverage models that allow us to manage care more effectively?
The affordability of health care is directly related to the cost of healthcare services. So, as I thought about what I would say today, I think the number one thing that we have to collectively consider is what we're actually paying for the services that are being rendered. Are they reasonable? Are they appropriate? Are they necessary? Is there any alternatives? And why do some things cost what they're billed out at? I've got some examples for you. We had a back surgery claim recently that was submitted, and this actually was from a Montana organization. Total billed charges were $214,000. The supplies in there were the vast majority of the expenses. And when you break them down and looked at it, we were actually billed $5,800, $5,800 for one titanium screw. Now, that's outrageous.
The system is not rational. Things are not being sold by hospitals at what I would call a street value or a market value sometimes.
There is no question in my mind that if we can create different payment models, providers can choose in a cooperative way to be more accountable for costs and deal with some of the issues that Mr. Vischer is talking about. It would take me most of the afternoon to give you my views on the complexity of how payment works and why some charges are a multiple of the actual cost. And I'm really not going to attempt to do that except to say that there's opportunities on both the insurer side and the provider side to do a better job with this. We probably could use some relief in a regulatory sense too, in terms of how we're required to submit charges. And of course, vendors who provide implantable devices also put prices on those that would surprise you in terms of what it costs us to purchase those supplies. You know, analyzing where the costs are in the healthcare system, they're in a lot of different places. In fact, the McKinsey Group did a study about a year ago that looked at why does U.S. healthcare cost per person twice as much as it does in advanced European countries. And there was no silver bullet. It was across the board. It's with the insurers, it's with the pharmaceutical companies, it's with the vendors, it's with the physicians, it's with the hospitals.
What we need is more efficiency, and well, what we need is a different premise. We have enough money in the system, we just have a management problem.
I believe that we've basically pursued the same approaches to healthcare delivery and healthcare financing for the last 3 decades. And as they say, insanity is doing the same things over and over again and expecting a different outcome. We've gotten the outcomes that one would expect from antiquated approaches on the insurer side and on the healthcare delivery side. And that's very concerning to me. I do think that we need to do fundamental thinking about what we're doing in terms of claims payment, provider payment, billing, the complexity that Dr. Creighton, Dr. Wolter, and others have referred to.